It's 6 minutes after the hour, 19 degrees outside our KTDR studios, and today we have a special edition of the Phelps Health program, and your host is, I think, still Summer Overshon.
I think that's still my name. Good morning, Lee. How are you?
Good morning. Good to see you.
So today is an exciting day because not only are we broadcasting live on air, but we're also broadcasting live on Facebook. So we welcome everybody that's listening today, and we hope that this takes off. So today we have Dr. David Mutch, who is a gynecologic oncologist with the Siteman Cancer Center. And he focuses his practice on gynecological cancers, including endometrial cancer, vulva cancer, cervical cancer, and ovarian cancer. And I hear that you are consistently recognized as one of the best doctors in America. That's quite a title. That's why we gave you the fancy chair.
I see. Thank you.
Yeah, you're very, very welcome. So how did you get into oncology to begin with?
Well, my dad is an OBGYN in Sioux Falls, South Dakota, and I always thought that I would go back and practice with him. And then one thing led to another. I was interested in subspecializing, and I went to Duke and did a fellowship in gynecologic oncology, and then came back to WashU, and that's what I did. So I'm not sure exactly how that happened. It just the path that life took me.
Right, right, and you've been successful in it. So today we're going to be talking about genetic testing, which is an interesting topic, and it's kind of a hot topic. Later on, as I was researching this, we'll get into some of the reasons why I was like, oh my goodness, yeah, I hadn't thought of that aspect of it. But this is something that we're hearing more and more about, that people are kind of hearing, and we need to talk a little bit about what and when is this a good idea for people. So what is it, essentially, just at its core?
So everybody, of course, has 23 chromosomes and 46 chromosomes, 23 pairs. They are, what we become is part of the genes that are contained in that DNA. And now, since the early 2000s, late 1990s, we were able to actually sequence that DNA and identify differences in human beings and animals and other plants and so on that have the DNA as sort of the building block of life, if you will. And we've identified then several genes now within that DNA that code for proteins that make us what we are, that might predispose individuals to certain diseases. So an example of that would be people who have hemophilia, have a mutation in that gene. People who have sickle cell anemia will have, specific mutations. And then people with cancer, actually there is a significant portion of them, up to 25%, who have an inherited type of cancer. That is, they are predisposed to that cancer. And we can test for that by sequencing, by drawing their blood and sequencing their DNA.
So what would be some of the benefits other than when a patient comes to you, let me rephrase this, and you're talking about possibly having some genetic testing done, what are the kind of the benefits to him or her about having that done? I mean, is it for family reasons? Is it for themselves, or is it a variety?
Initially, the best reason that I think would be to identify that your family has this gene. And then we would recommend what we call cascade testing, where relatives and relatives of those relatives and so on are tested, because that gene can be replicated, if you will, within the family and in other generations, and certainly subsequent and past generations. Most recently, though, we're learning that it's important to know whether or not these genetic abnormalities exist in the individual, because there are targeted therapies of their cancer that can be utilized now. An example would be a PARP inhibitor. People in the audience may have heard about Lynparza or rucaparib, or Rubraca, that are PARP inhibitors that will be able to treat patients with certain genetic abnormalities. Patients who have a mismatch repair defect in their DNA their cancers may actually be susceptible to something called Keytruda or pembrolizumab. So as we learn more and more about the genesis of cancer, it's becoming increasingly important to understand the molecular features of the cancer, because there are non-toxic therapies that can actually treat or even cure that cancer.
So how would a person know if he or she was a good candidate for genetic testing anyway?
Well, so you don't really.
Okay.
We recommend that all patients with ovarian cancer get tested. And we recommend that, now I think the recommendations are that most people with breast cancer get tested. We test all of our patients at WashU, and we also test the tumor, because the tumor can acquire mutations that might not be inherited, that are similar to the inherited mutations that would make that cancer susceptible to specific and targeted treatments.
So if a person does inherit a cancer mutation, does that mean that they are going to get cancer?
No, still it's a random event. In other words, so most of the cancers that are inherited, at least as solid tumors, that would be ovary, endometrium, our tumors, gynecologic cancers, are the result of genes that repair abnormalities in the DNA. So as we live, of course, we acquire, mistakes are made as cells divide in the DNA. And there are very good systems and reliable systems within our bodies that will repair that DNA as those abnormalities or errors occur. If there's a failure in that system, then of course you can see that these errors will continue to accumulate, and that's why, and that leads sometimes to development of a cancer. If you have an inherited mutation, so you can't repair that DNA early on in your life, of course that cancer may occur at a young age. That's the heralding feature, in fact, of inherited cancer is early age of onset.
Mm-hmm.
So it's important, so that's so you would like to know if your child, or if you have the mutations, you might have passed it to your son or daughter, and they could be screened, if you will, for these cancers, or even have, their ovaries removed at an early age, for instance, before they got the cancer, or, for instance, oral contraceptives will diminish significantly the likelihood that one will get ovarian cancer. It works in patients with inherited disease too. So if your daughter, for instance, were 25 and not yet married but wanted to have children, certainly chemoprevention or oral contraceptives would be a good route for her to go until she decided to conceive.
Now, do you find that they're receptive to having genetic testing done, or are they resistant? For fear reasons.
Well, when we first start, there are lots of reasons for people not to do this. The first reason, people are fearful of insurance implications, that it will alter whether they're insurable or not. If you'll remember, when President Clinton was president, there was a law passed that said that one cannot discriminate against an individual based on their genetic makeup, and so that is illegal, and so that should be noted by everyone, and so that would be a risk. Whether or not you'd be insurable for life insurance and so on could also be a factor of not doing that. Another would be fear. That's correct. Sometimes you might not want to know. And there is incredible guilt associated, for instance, with a mother realizing that she's passed genetic abnormality on to her daughter, even though it had nothing to do with her. It wasn't her fault.
But you still feel responsible.
That is correct. But I think less and less, and I think with the advent of, for instance, Angelina Jolie having her prophylactic surgery, that sort of raised awareness but not understanding of the disease. So the burden of helping patients understand the implications of genetic difference it falls upon the physicians to educate the population. this.
Hopefully we're doing that right now.
Exactly.
So what kinds of genetic testing are available to patients, and how is this even done?
So probably the most frequent way to test would be by drawing blood and then extracting the DNA from white cells and testing DNA that way. You can do it with a buccal smear, that is scraping cells from the inside of your mouth and sending that, like 23andMe will sequence your DNA on that basis. So actually that may be the most common, because that's what people typically do, and send in their buccal swab to the company and have their DNA sequenced for hereditary reasons. So it's very similar to that, and in fact those genetic or companies that do that are also getting a little bit into the realm of testing for predisposition to disease. I mean, do you have X, Y, or Z mutation? If 23andMe identified such a mutation, then I think you probably want to have that verified by a CLIA or an approved laboratory before you acted on it clinically.
Okay.
Summer, we actually have a question
Okay.
from Facebook.
Fantastic.
James Hedrick asks, if a patient's tumor biopsy shows gene mutation, but the markers in that patient's blood work do not show the gene mutation, would it be recommended for family members to be checked for the gene mutations?
Typically not. That would be something called a somatic mutation. That would be a mutation that's specific to that tumor. In other words, tumors develop because they accumulate mutations, and they'll continue to accumulate mutations. So those DNA abnormalities are often not reflected in the host blood. So the abnormalities reflected in the host blood, the patient's blood, are usually germline. That is, they're part of every cell in that patient. Somatic mutations would be those, or tumor mutations are those mutations acquired by the tumor. Both are useful. If you have if your tumor has acquired a BRCA1 or BRCA2 defect, but you are not, but your blood doesn't show it, still the tumor will likely respond to treatments for patients for BRCA1 or BRCA2 mutations. It doesn't necessarily have to be what we would call a germline or an inherited mutation. It can be an acquired mutation by that tumor. Did that answer the question?
Yeah, I think so. So what are the results of genetic testing, and what does it mean if you get a positive result or a negative result?
Well, I don't sort of like, that's, people ask you that, well, you have a BRCA mutation, was that positive or negative?
Right.
No. I wouldn't say it's positive, or, positive in my mind would imply that the mutation is there.
Okay.
Negative would imply that the mutation is not there.
Okay.
But I think the physician should be more specific. You have a BRCA1 mutation, and this is what that mutation is. This is what it means to you and to your offspring. We should test your children, your brothers and sisters, perhaps even your mother and father, if they're alive, aunts and uncles, and so on.
So if it is a particularly aggressive cancer, let's say, and they are more predisposed to getting that cancer, how do you make a choice to do what Angelina Jolie did? Is that a conversation that you have with your physician? It's case by case, it has to be, but how do you go about starting that conversation?
Well, I think that you would say, if the patient has a hereditary predisposition for an ovarian cancer, for instance, you could say that by the age of 70, the likelihood that you will get an ovarian cancer, acquire that disease, develop that disease, would be in the 60 to 70% range.
Okay.
That is over, though, the course of your lifetime. We typically would, obviously, if the patient is 23 and has not yet had her children, in this case I'm assuming that it's a woman, you probably would, then you might want to, but yet she doesn't want to have children at this time, then you'd probably want to place her on oral contraceptives to reduce her risk. And then you'd want to have a continuing conversation with her. Now she's 33, and let's say, and has had 2 children, and doesn't want any more, or 3, and then you would probably have start having the conversation about whether or not she'd want her fallopian tubes and ovaries removed. And then that conversation obviously wouldn't center around childbearing anymore, but would center around surgically induced menopause, which in a 35-year-old wouldn't exactly be desirable. On the other hand, getting ovarian cancer is not desirable either. So that would be an individual decision that a patient would have to work out, within their family, within their marriage, within their relationships, and then, of course, with their doctor.
Right. And that's one of the reasons I could see why it's so important to establish a relationship with your physician, because these conversations can be very, very difficult. And I would think that if you are with someone that you trust, it's easier to talk about those things.
Well, certainly longitudinal care with continuity is the ideal situation, yes.
So what is a genetic counselor then?
So genetic counselors are invaluable, and there are not enough of them. They are the individuals who will help you sort out your risk of developing the disease, will help you make a decision, and they will help with a recommendation with the physician as to whether or not the individual should be tested. They will assess risk for you and help you explain that risk to, if you have the DNA abnormality or the mutation, to the rest of your family members. They will help you cope with what the sequelae are from informing your family and so on, and help them understand their risk. So genetic counselors are becoming incredibly, well, they were always important, I guess we just didn't realize it. Now we're realizing how important they are, and we need more of them.
So when should you be meeting with a genetic counselor? Before you get your test done, after you get your test done, all of the above, or does it just depend?
Well, that's a good question. We used to just send our patients who were at risk to a genetic counselor.
Mm-hmm.
Patients with ovarian cancer, endometrial cancer, and may just everyone would get tested now. So I may test them, counsel them briefly, test them, and then send them to a genetic counselor.
Okay.
That would be not a wrong way to do it necessarily. It just depends what the level of comfort is with the physician and his or her relationship with their patient.
Yeah. So let's circle back to the at-home test for a moment. Because you do see more and more of that. You see television commercials about, order your kit online, get your results. In your opinion, are these effective and are they reliable?
Well, certainly those 23andMe, for instance, or other companies do actually a very good job of assessing your genealogy. They are now branching into the realm of genetic abnormalities that might predispose one to a disease. But again, that is not a clinically approved test, I don't think, in most settings. So they are, though, reliable, pretty reliable. Obviously, we've heard of crimes being solved because of individuals who have had, even relatives of individuals who've had genetic testing done, and the DNA from the crime scene, for instance, is similar to the DNA of one of the individuals who chose to get tested. But it is, most of the time, I don't think that these are, as I said, approved laboratories to have, on which the basis of clinical decision should be made.
Right. Because I guess I'm thinking about the person that gets results back and makes some sort of rash decision. We don't want that. I mean,
They won't. I don't think a physician would
Yeah.
or should make a decision on a basis of that kind of test. I mean, you
would do further testing first.
That is correct,
Right.
and then make a decision. That is exactly correct.
So what research is being done to improve genetic testing right now for cancer?
Oh, well, just mostly the quality of the DNA testing that we have is high. The information that we have is constantly growing. That is, we've sort of identified the low-hanging fruit, BRCA1, BRCA2 mutations, mismatch repair, and I could name 50 genes that we have targeted. But what about like lesser gene or what we perceive as less important genes that might be mutated and predispose an individual to that cancer. Those are, that is a work in progress. I mean, weren't even able to test people. Remember, it was $100 million to do the first sequencing. So Maynard Olson and Bob Waterston at WashU, had a big team, and they sequenced the first human genome in the academic setting. And then, of course, there was the private sector that tried to do the same. And that was $100 million. I can do better gene sequencing now, just 18 short years later, for like $1,000. So, what will be 20 years from now? We don't know, but I'm presuming that it will be cheaper, better, and faster, and we'll know, and we'll be able to get more information because we'll understand the differences better. So I'm thinking we'll also understand the downstream products, the RNA and the protein that are made by those genes. So, I think that maybe there won't be that much technical advance in terms of the sequencing part, but certainly in the gathering of information and understanding what the results mean will grow increasingly better.
Right. And this is just an overall question. What strides are we making in the fight against gynecologic cancer right now?
Well, cervical cancer, remember in the 30s and 40s, cervical cancer was the second largest cancer killer of women in our country. It still is worldwide, but because of screening technology, it's way down on the list. There used to be 80,000 cases in the U.S. a year in those days. Now the population is much greater, and there will be 11,000 cases in the United States this year.
Wow.
So we've made huge inroads
Yes, we
there.
have.
Yeah, and endometrial cancer is a problem. The incidence is increasing and the mortality is increasing. It's one of the orphan cancers. I attribute that largely to, I think we need more NIH funding for that disease in an effort to understand it better. We understand a lot of things about it, we just haven't been very good at preventing it. Certainly does not help that the size, if you will, of our population is increasing in terms of, obesity is a large problem in our society. That is a contributor. Ovarian cancer, we are making great strides in terms of treating the disease. So patients are living longer with their disease. And when I was a fellow in 1984, the median life expectancy of a patient with ovarian cancer was 24 to 36 months. Now, it's 60 months or 72 months, 5 or 6 years, and I have patients who are 20 or 30 year, 25 year cancer survivors.
Amazing.
So, because we have lots and lots better treatment, but we need better preventive techniques.
Right.
So I don't get the disease in the first place. And certainly genetic testing will not affect everyone, but about 15 to 20% of patients will have inherited disease. We could prevent that. That would be wouldn't be a home run, but it would be maybe a double.
Right. That's exciting and true. We've been speaking today with Dr. David Mutch, who is a gynecologic oncologist with the Siteman Cancer Center. I will say that we do have genetic testing available at Phelps Health at the Delbert Day Cancer Institute, and you can learn more at phelpshealth.org. Thank you so much for being here.
Thank you.